Thank you very much for the invitation to come speak. It's been a long time since I've been back here at my alma mater. I have a lot of fond memories of the GI Pathophys course, which I think single-handedly has convinced probably dozens, if not over 100 people to go into GI over the years. It's also good to see a lot of familiar faces back from former fellows as well. So today I'm going to be talking about Barrett's. I'm not going to talk too much about endoscopy and endoscopic treatment, which is good since it sounds like a lot of that was covered previously. These are my disclosures. So I'm not really a storyteller like Ira Glass, but I've sort of tried to divide this talk up into three parts. So we're going to talk about risk factors. I'm going to cover also, obviously, the established ones, but I think there are also some new and very exciting risk factors that are being discovered in the past few years. In the second part, I'm going to cover screening for Barrett's esophagus. And then finally, in the last part, I'll talk about new directions in Barrett's management. And so, I mean, I don't think I need to tell most of you that esophageal adenocarcinoma garners a lot of attention, largely because of this really dramatic rise in incidence over the past half century. We had previously looked at Connecticut tumor registry data. This is one of the SEER sites. And if you look really back in the 1940s, 1950s, even the 1960s, for many of these years, it's really single digits of cases of esophageal adenocarcinoma. And then really in the late 60s, you just see really like straight line up in the age-adjusted incidence. The reason this is important is because this cancer has a particularly poor prognosis, which hasn't improved a whole lot over the last 30 years. Still less than 20% 5-year survival. A lot of this is because really relates to the fact that we don't diagnose esophageal cancer until it's symptomatic, at which point likelihood of cure is relatively low. But even with early stage cancer, you can have stage 1B cancer where it's only into the submucosa, and these patients oftentimes can have high rates of lymphatic spread, depending on the series you look at, maybe even up to 50%, probably somewhere more in the order of 20 to 30%, depending on how deep within the submucosa these tumors are. And then even after apparently curative resection, you get very high rates of local and distant recurrence. And because of this, there's really sort of a lot of attention to esophagus, which is the precursor to esophageal adenocarcinoma. And we think that by identifying Barrett's, perhaps we can actually either prevent cancer or at least lower esophageal cancer mortality. In terms of risk factors for Barrett's, this is a sort of a older white men disease. The ratio in Barrett's of males to females is 2 to 1. Esophageal adenocarcinoma, it's a lot more pronounced. It's about 8 to 1. The average age of diagnosis is about 70. Obesity, particularly central obesity, probably relates to the amount of visceral fat, is a moderate risk factor. Smoking is also a moderate risk factor. High dietary fat, low dietary fiber are also associated with increased risk. H. pylori infection of the stomach, interestingly, is associated with a reduced risk, a sort of a markedly reduced risk of esophageal cancer, and I'll talk a little bit more about that in a minute. There are a couple of new possible risk factors for Barrett's. One is obstructive sleep apnea, and this seems to be independent of obesity. This was a nice study done in the Mayo Clinic a few years ago, and they found that obstructive sleep apnea, they basically looked at patients who had had sleep studies at their center as well as EGDs, and then they compared how many had Barrett's based on these sleep study findings. And the odds ratio was almost 2, and this was independent of age, sex, GERD, BMI, and smoking. And there seemed to be a dose-related effect as well, whereas, in other words, the worse the apnea-hypopnea index, which is a marker of severity of sleep apnea, was associated with increasing odds ratios for BE. Possible reasons for this: with sleep apnea, you generate very negative thoracic pressures as your diaphragm is really trying to pull down, and that may induce more GERD. But also possibly that may also be because of increased mechanical strain in the posterior lower thorax, And we certainly have some data from pulmonary fibrosis, where you can actually see in patients with severe sleep apnea this sort of geographic distribution of fibrosis in these posterior lung fields. And this is exactly where the esophagus passes through the diaphragmatic roof. So there may be some element of sort of mechanical strain leading to chronic inflammation there as well, which may contribute to Barrett's. A new possible risk factor, this is obviously doesn't affect a lot of people, but been doing some work with in cystic fibrosis recently. And there, as you may or may not be aware, it turns out that CF patients actually are at very high risk of various GI malignancies. And we're only starting to learn this now that CF patients are living for much longer. The average life expectancy now is about 46, and that's expected to continue to rise, possibly into the 60s or 70s with the current birth cohort. And in this study that was published in the JNCI 4 years ago now, using data from the CFF patient registry, comparing age-adjusted incidence from SEER, we found that the risk of digestive cancers was about over threefold higher, and in colon in particular was about sixfold higher. Interesting, there's also about a threefold increase in esophagogastric cancer. And it turned out, in speaking with the one of the lead investigators, these were really all esophageal and GE junction adenocarcinomas that they had seen. So it sort of raised the question, do CF patients have an increased risk of Barrett's? At least from case series, they have a lot of reflux, but there isn't much known about Barrett's. So we decided to look at our data at Columbia over about an 11 to 12 year period, looking at all the CF patients who had undergone endoscopy, match them to non-CF patients with age, sex, year, and endoscopist. And what we found is that the CF patients had about a threefold increased risk of Barrett's, sort of matching what was seen from the esophagogastric cancer risk as well. But they get this at a very early age, so really less than 40, which is much younger than we're seeing in the average risk population. And most of these patients actually had lung transplants prior to that, so it's probably a combination there of having CF plus the immunosuppression. Possible reasons for this: CF patients have high rates of reflux, but there actually is also some data that the CFTR gene may be a proto-oncogene, and so when it's mutated, that could explain why you get some of these high rates of cancer. So, CF isn't obviously going to explain this rapid rise in incidence in esophageal adenocarcinoma. So what does explain this? I mean, this is really pretty dramatic. There has to have been some, major shift in environmental exposures, if you will, in the population that can account for this. And if you read papers, read the introduction section, a lot of papers about Barrett's, we'll always cite obesity as one of the main culprits for the rise in incidence. But is obesity really responsible for this? So, if you actually look at time trends of incidence of obesity, obesity didn't really start to rise in the United States until about the mid to late 70s. Now remember, the esophageal adenocarcinoma started to rise either early 70s, late 60s, which means from an epidemiologic perspective and exposures, something had to have preceded that by probably at least 10 or more years. So this seems to not explain at least the initial rise. And then some nice modeling work was done by Chin He and his group up at Harvard to try and estimate how much obesity is actually contributing to this rise in incidence. And this combined with the fact that obesity didn't start rising till later. Also, obesity is not a strong risk factor for Barrett. It's only odds ratio of about 1.5 among the sort of the highest quartile of either BMI or waist to hip ratio, whichever measure you choose to look at. And so they really estimated that obesity can only account for about 6% of this massive rise over the past half century or so. So what does explain the rise in incidence? So one other possibility is reflux. This was another modeling study published a couple of years ago, and they tried to estimate how much does reflux contribute to this as well. And they estimated from their modeling, I don't fully understand how they did these models, but they estimated that really the reflux, which would be a combination of either, which is really demonstrated by this red area here, only accounts for a relatively small proportion of the esophageal adenocarcinoma cases that we see. And this green area here really accounts for some other factor that they call this sort of unidentified other factor. So even GERD and obesity together don't seem to account for it. Other risk factors, smoking, wouldn't account for it because smoking rates have been on the decline for quite a while. And again, smoking is not a strong risk factor for it. So it's a little unclear what could be causing it. And it kind of raises the question, you have to go back and look at the time trend. So what really, what could have occurred in the middle of the century here to explain this? And I think one of the things to me that stands out is this decline in H. pylori. I mean, H. pylori has really declined dramatically, probably from about 80% to somewhere between 10 to 20% in terms of infection prevalence in the U.S. And now, whether or not H. pylori is directly responsible for having a protective effect against Barrett's is unclear. One thing we do know, though, is that certainly there is a very distinct upper GI microbiome in the presence and in the absence of H. pylori, and so there could be other factors at play there. And so why have we seen this decline in H. pylori? Part of it is due to widespread antibiotic use, and then also changes in diet could be influencing the microbiome as well, something I haven't talked about too much, but there is evidence that really there's been a really pretty marked increase in this consumption of dietary fat and processed foods as well. And, so kind of all points to, could the microbiome be playing a role in this? I know it's sort of a faddish topic right now, but I think it sort of fits very nicely for esophageal cancer, much more so than for a lot of other diseases in terms of when you start to look at the epidemiology and the incidence trends. So it turns out when you look at the esophageal microbiome, very similar to the oral microbiome with a very high relative abundance of the phylum Firmicutes, and Streptococcus is really almost dominant in terms as a genus here in the esophagus, and which is also seen in the mouth as well. Most of what we know about the microbiome in the esophagus and Barrett's is really just associations between them, and there aren't that many studies. A lot of this has to do with the fact that it's kind of hard to sample the esophageal microbiome. You need to do an endoscopy, whereas with the mouth you can non-invasively sample, or with a stool you can also non-invasively sample. So what do we know about the microbiome in Barrett's? This was a study done out of the University of Washington, and what they found was that as you sort of travel down the upper GI tract, going from squamous to Barrett's to body to antrum, there's really very, very little change. And you can, what this shows here, this is just a principal coordinates analysis showing that within an individual, these different sites cluster very tightly when they're plotted. These principal coordinates is just sort of a two-dimensional way of trying to plot all of the microbiome data about recounts and all the different taxa that are seen there into a single point in space. But there is a fair amount of variability in between individuals. A study that was done a few years ago where they did biopsies from patients with Barrett's of squamous tissue just above the squamocolumnar junction, patients with Barrett's and esophagitis, and then normals on endoscopy. And they really found little difference, at least in the squamous tissue microbiome here in terms of specific taxa. They did find, though, that there are really pronounced differences in the bacterial makeup of the gastric aspirates. Now, whether or not that's relevant is unclear, but certainly, certain patients with esophagitis and Barrett's will have a lot of exposure to whatever's in the aspirates. And they did have high relative abundance of Enterobacteriaceae, and that family includes a lot of gram-negative taxa that have been implicated in terms of tissue inflammation, and even carcinogenesis, mostly from data from the colon. Probably the most cited study is one done by Jihang Pei and his group at NYU, and this is now 9 years ago. And again, these were endoscopic samples where they looked at a small number of patients. There's 34 total patients with Barrett's, erosive esophagitis, or normal. They did 16S sequencing, and then what they did was they just did what's called unsupervised clustering. So they just wanted to see, if we do clustering analyses, how do these fall out, and does it look like one group is different from another? And they found that there were sort of two main clusters here, and they just arbitrarily called them type 1 and type 2. And it turned out that this type 2 microbiome here was made up almost exclusively of either Barrett's or erosive esophagitis patients. And when they went and looked at, what was it that made them different, they found that the type 2 microbiome had significantly decreased relative abundance of streptococcus and increased gram-negatives. And as a result of this, they sort of hypothesized that perhaps these gram-negatives, which can induce tissue inflammation, may be playing some sort of a causative role here in terms of esophagitis and Barrett's esophagus. Again, these are all just associations, though. So we did a study that was presented last year at DDW, and we looked at microbiome alterations in Barrett's patients and in cross-sectional study, as well as low-grade, high-grade dysplasia and early esophageal cancer, just sampling the normal-appearing areas. And in terms of diversity, there are no differences between them, but we did find that it seemed as you go from low-grade to high-grade, you start to see this shift here in the microbiome, at least at the phylum level. So that's sort of the 30,000-foot picture here. And then, but there were some very specific taxa as well as you get to the high-grade dysplasia in cancer patients, including increases in the Enterobacteriaceae again, which came up in that prior study of gastric aspirates, and including Proteus and several other gram-negative bacteria that hypothetically could be contributing to tissue inflammation and promoting progression to cancer. There is some experimental data to support a causative role for bacteria in progression from Barrett's to cancer. And this is from Michael Quante in Munich. This is unpublished data using the IL-1 beta mouse model that was developed in Tim Wong's lab. And under germ-free conditions, they found that you had much lower rates of development of dysplasia in these mice. And then when you reintroduce the bacteria, then the rates go up again. I had mentioned also that diet was a risk factor for Barrett's and esophageal cancer. Dietary factors: high dietary fat, low dietary fiber. The mechanisms behind this, unclear. Dietary fat is about a twofold increased risk. And from a meta-analysis that was published a few years ago, the high fiber consumption was associated with about a 35% reduced risk of esophageal adenocarcinoma. And so it raised the question, well, what is the explanation for these associations? And at least for some data that was published last year using Nurses Health Study cohort in JAMA Oncology, really a very nice study, and they took their colon cancers and looked at F. nucleatum. So Fusobacterium nucleatum is a bacteria that seems to have, I would say, very solid data at this point to support a causative role for colon cancer, at least in a subset of colon cancers. It seems to be present maybe in about a fifth of them. And what they found was that that the individuals in the cohort who consumed a prudent diet, which these were sort of arbitrary names that they gave them, it turned out this prudent diet happened to be very high in fiber, was associated with a pretty markedly reduced risk of colon cancer, but that effect was really only seen in F. nucleatum positive colon cancer and not F. nucleatum negative colon cancer, and at least implies that the effects of diet on colon cancer risk are mediated by changes to the microbiome. And so we decided to look at whether or not diet influences the esophageal microbiome. And so using that same group of patients that I had described earlier, we looked at brushings from the squamous esophagus, and all the patients completed a 4-week food frequency questionnaire that was validated for fat and fiber intake. And what we found is that there are no differences in microbiome diversity, but increased dietary fiber intake was significantly correlated with increased relative abundance of firmicutes, decreased relative abundance of proteobacteria, and decreased relative abundance of gram-negative bacteria as a whole. These associations didn't seem to be influenced by patient characteristics, including Barrett status, and there were some very specific changes at the taxon level as well, and the patients with low fiber intake had increased relative abundance of Neisseria, Prevotella, Eikenella. Again, these are all bacteria that can promote inflammation, have been associated with infection. And so, at least raising the possibility that, low fiber intake, the association between low fiber intake and esophageal cancer risk could be mediated by changes to the microbiome. We actually found very little association between dietary fat intake and the microbiome. Things to keep in mind there is, one, this is not a huge sample size, and also it turned out that the spread of fat intake in our population was not very large, so we weren't really getting a good look at least in terms of the extremes of fat intake there. Yeah.
One of the reasons I thought that the microbiome in the colon is so important for epithelial biology is because not only do you have zillions more bacteria than the esophagus, but it's an area that is processing the food, processing the fiber. The esophagus, the food is just sort of passing through. So if there is an effective diet, what do you think the mechanism is?
Yeah, I don't think that the mechanism relates to sort of food sitting in the esophagus and that directly alters the microbiome. I think more likely it may have to do with alterations to the colonic microbiome, which may have more systemic effects, which then downstream have impacts higher up, or perhaps just fiber intake is just a marker for something else about the patients that corresponds to a different microbiome as well. And I mean, who knows, maybe they're just to do a better job of toothbrushing or something like that if they eat a lot of fiber. So
there's an article in the Times this morning from a paper in Science about the microbiome in colon cancer, citing Bacteroides and E. coli, or certain strains of E. coli, as being carcinogenic in the colon. And you're telling us that different bugs are carcinogenic above, different bugs are carcinogenic down below.
So most of what we know, at least from I'm not going to diverge too much, but most of what we know about the colon and specific bugs comes from mouse studies, and there really is some very nice work in mice here to show that. I would say from the upper GI tract, outside of H. pylori aside, we know very little about any potential causative mechanisms. Largely because it's very hard to do mouse studies of the upper GI microbiome as well. And the mouse microbiome is very different. Mice are coprophagic, so they really end up being colonized with their colonic bacteria, which is different from humans as well. So.
Is it possible that, has anybody made a correlation between the presence of H. pylori in the stomach and the microbiome in the esophagus? I mean, this whole concept of bacteria sort of preventing other bacteria from taking hold. I realize that H. pylori is in the stomach and in the esophagus, but is it possible that in the presence of H. pylori it keeps other bacteria from taking hold?
Yeah.
Now, competitive niche, and once the H. pylori goes away, you get new flora, you see more Barretts.
I think that's the most likely explanation.
So that,
it's
interesting to do the same studies and control for H. pylori status in the stomach.
Yeah, that specific analysis hasn't been done, but it does seem that there's the gastric, and this includes the cardia as well. there's the H. pylori positive and H. pylori negative microbiome that are very different. And within an individual, there's really very little variability as you go along here. So I suspect that what you see in the stomach, in the absence or presence of H. pylori, is going to be very similar to what you see in the esophagus. You don't see the H. pylori in the esophagus, but the other bacteria are very similar. And so, this sort of to try and summarize some of this. Again, this is a very early field, but how might bacteria be contributing to Barrett's? So I had mentioned gram-negative bacteria. They express lipopolysaccharide. This can induce tissue inflammation. Can stimulate the NF-kappa B pathway, which has been implicated in Barrett's and its progression to cancer. At least in the colon, it seems that short-chain fatty acid production by Clostridia in particular may be very important to sort of preventing inflammation and protection against both inflammation and possibly cancer. It actually turns out, we actually just recently looked at that, these Clostridia are actually virtually absent from the esophagus, so that may not be as relevant here. And then the mucus layer, specifically in Barrett's, produced by goblet cells that contains antimicrobial peptides. And then there's some evidence that bacteria can actually also induce epigenetic changes. And this, at least this has been shown in the colon, that F. nucleatum is associated with CpG island methylation and the sessile serrated pathway. So moving on now, I'm going to talk a little bit about Barrett's screening, and only because this is something that I think you're going to be hearing more and more about over the next several years. So, one of the big problems with esophageal cancer is that the mortality is so high, and this combined with the rising incidence is really sort of what's why a lot of attention is paid to it. And this is just sort of a nice figure from paper from Tom Vaughan and Rebecca Fitzgerald from 3 years ago, and really sort of highlighting the fact that these esophageal cancer patients, we don't diagnose them with Barrett's beforehand. Probably, more than 90% of the cases never get a Barrett's diagnosis. And so they're highlighting here is if we estimate there are about 10,000 adenocarcinomas per year in the U.S., it's probably a little bit higher now, that we're only catching about 700 of these patients beforehand. So theoretically, missing the opportunity to intervene at a sort of a precancerous stage to try and reduce mortality here. So one potential solution would be to identify many more patients who are at risk, and specifically, let's flush out all these Barrett's patients. And so that's sort of one thought. Now, we could just do endoscopy on everybody, but it turns out that that's really impractical and cost ineffective. And so it's expensive, it's invasive, it requires time off. And so I think there's a real push to try and come up with minimally invasive techniques to diagnose Barrett's. Now, if we're going to be screening for Barrett's, who should we be screening? So if you look at the societies, they provide minimal guidance, I would say. So the AGA says you can do a screening endoscopy for patients with multiple risk factors, but they don't say specifically who should be screened. ACG just says who the highest yield for Barrett's is in older Caucasian males with long-standing heartburn, but they don't actually recommend doing screening. And all these recommendations are really based on expert opinion. Further complicating endoscopic screening for Barrett's, even among gastroenterologists, that's not routinely or consistently done. And primary care physicians rarely refer patients specifically for Barrett's esophagus screening. So, if we're going to do screening, though, we want to make sure we're actually targeting the right population, so we don't do a whole lot of unnecessary testing. And so can we identify these patients who are at highest risk for Barrett's and thus esophageal cancer? There have been some clinical prediction models that have been put together to try and see if we can really target the people who we should be focusing our resources on. This study from the VA by Joel Rubenstein, where they took over 800 patients, male VA patients who were undergoing screening colonoscopy, and invited them to do an upper endoscopy. They found Barrett's, I believe, in about 7% of them. And based on the information that they gathered from these patients, they came up with predictors of Barrett's and a model to try and identify them, which they called the M-Barrett model. And you can see here that the things that went into it were at least weekly GERD, older age, waist to hip ratio, and smoking history. And that came up with an area under the curve of about 0.72, which was better than GERD alone. But I don't know how familiar you are with predictive models. That's not great. It's okay, but it's not great for identifying Barrett's. So then another study that was done by Hashim El-Sarraj and Aaron Thrift, where they looked not only at clinical variables, but they also drew blood on patients, and they looked at some circulating cytokines that they had previously identified as being potentially associated with Barrett's. And when you add these cytokines to the clinical variables, they were actually able to get their area under the curve up to 0.85, but it was only marginally better than a model with just the clinical variables alone. Their clinical variables model was actually up around 0.8. So, we're okay at diagnosing Barrett's or identifying the patients who should be targeted for screening if we're going to do screening. So then the question is, can we diagnose Barrett's without an endoscopy? One possible way of doing this is transnasal endoscopy. This is something that you can just do in the office setting. Patients don't have to come in. They don't have to get sedated. They don't need an IV. They don't need an escort. You can get good visual identification of Barrett's with it. You can get some tissue sampling with it, with the sheath that's there. It's limited, but you can get some. And it's feasible and acceptable to patients. This was a study, Prasad Iyer did this at the Mayo Clinic, where they went around with this mobile research unit and invited patients. The patients were randomized to be invited to either the mobile transnasal endoscopy in this endoscopy suite or standard endoscopy. Roughly less than half of the patients agreed to undergo the transnasal endoscopy, which was about the same as for the standard endoscopy. They were able to get a complete evaluation almost 100% of the time, and 80% of the patients said they would undergo the transnasal endoscopy again. So it's a doable test. It's like I said, it's office-based. Now the downside is that you still need probably some sort of GI specialty, either the physician or nurse practitioner, somebody to do this, as opposed to being, for example, a primary care office-based test. This isn't something a primary care physician is going to do when they also have to assess your obese patients who also have diabetes and hypertension and heart disease, and then go ahead and do their T&E. So one test that has been pretty well studied and is quite far along at this point is something called the cytosponge. And what this is a little capsule on a string. The capsule is 2 centimeters long, so it's about the size of some multivitamins, or it's actually the exact same length as a Dayquil, but it's narrower. So Dayquils I find hard to swallow, but and basically you swallow this. It goes down into the stomach. It's tethered on a string, and so the person administering the test holds on to the string. You wait about 5 minutes. The capsule dissolves and exposes it's a very soft brush, and then it just gets withdrawn, and then that basically will sample cells along the entire length of the esophagus. And this was developed by Rebecca Fitzgerald at Cambridge. They had previously, through microarray analyses, identified TFF3 as a very specific marker for Barrett's esophagus. And so with the cytosponge, what they can do is then they can do immunohistochemical stains for TFF3, theoretically to diagnose Barrett's. So they published the BEST2 trial. This was a case control study of over 1,000 patients, and they did a cytosponge test prior to undergoing upper endoscopy. And the sensitivity was about 80% and specificity of 92%. For a subset of patients, they tested them 2 times. So if you got 2 tests, the sensitivity went up to close to 90%. And in theory, this can be combined with risk stratification biomarkers as well, either through immunohistochemistry or also to do sequencing. There's plenty and plenty of DNA there if you wanted to do any kind of sequencing. So now they're conducting the BEST-3 trial, which is a nationwide trial in the UK of over 9,000 patients being conducted at primary care physician offices throughout. And they're offering cytosponge testing. They're identifying patients based on whether or not they're on PPIs. And then basically everyone who's on PPI gets invited. There's some age criteria and some other criteria as well. And then they'll be invited to go to the cytosponge test. If they have a positive test, they'll get an endoscopy. For those who have a negative test or who refuse the test, they're on a subset of them. They're also offering endoscopy as well. And so we are also starting at Columbia. We're going to be starting soon a screening program using Barrett's as part of an IRB approved protocol. Full disclosure, this device is, at least in the US, is now owned by Medtronic, and I do consulting for Medtronic for this device. We're going to be identifying patients, at-risk patients, by screening the electronic medical record, and then testing in the primary care physician office with the cytosponge and doing endoscopy for these TFF3 positive patients. So in terms of other methods for screening, Amitabh Chak at Case Western has come up with his own device that he developed, and this is actually quite small. This is probably about half the size of a cytosponge. This is a very soft rubber, and inside there's an inflatable balloon, and this just gets inflated with a catheter on the with a syringe on the other end, and it has little prongs that don't really get much in the way of cells, but do get plenty of DNA. And so using this device, they looked for methylated DNA markers. That was a particular interest of theirs. And they identified two methylated DNA markers, both CCNA1 and vimentin, that seemed to be relatively sensitive and specific for Barrett's esophagus. And when they looked at their esophageal cytology brushings, these two markers gave you an area under the curve of 0.95, so very high. And with the balloon sampling, it's down a little bit, but still 90% sensitivity and 92% specificity. So this is another potential way to diagnose Barrett's. Our interest has really been in the in the microbiome, and so we were particularly interested in looking at the oral microbiome. And since we know that the esophageal microbiome in many ways mirrors the oral microbiome, and so the thinking was that if it reflects distal translocation from swallowed secretions, and if the Barrett's microbiome is altered, perhaps we can actually see that in the oral microbiome. And there is evidence from some other disease states that the oral microbiome can serve as a biomarker. So we did a case control study of patients without and with established Barrett's who were undergoing endoscopy, and we collected various samples from the mouth and from the esophagus, and then did 16S sequencing. And so we had 49 subjects, 17 non-Barrett's and 32 Barrett's. The Barrett's patients did run the gamut of having no dysplasia to early cancer. There were some differences between them in terms of patient characteristics. Interestingly, the non-Barrett's patients actually had higher BMIs, but there was no difference in the waist to hip ratio there, so really no difference in terms of the central obesity. And what we found was that there was, at least in the oral microbiome and the saliva, there was no difference in the alpha diversity comparing Barrett's with controls. But when you look at sort of beta diversity, and this goes to these clustering images again, and again, what it's trying to do is take all this data from a sample and put it into a two-dimensional space, a single plot. And what you find here is you get this really tight clustering of the non-Barrett's patients, and then the Barrett's patients are kind of all over the map here, suggesting at least that, at least in the saliva samples, that there's sort of this ordered microbiome in the normals, and then just in various directions becomes disordered in Barrett's. And this is actually a phenomenon that's been observed in other conditions as well. There's a distinct shift in the phyla. So Barrett's patients had much higher relative abundance of firmicutes and lower relative abundance of proteobacteria. And what this is a cladogram. And so this just shows differences between the Barrett's and non-Barrett's patients at the taxon level. And basically what this does is it goes from the inside, from the phylum level, all the way out to the genus level here, as you go from inside to outside. And really what this is just highlighting here is that there are really these very broad differences that we found in the saliva between the Barrett's patients, where it's increased in this region and decreased in the proteobacteria. And so then we went and looked to see if we could come up with a signature that actually might identify Barrett's patients. And relative abundance of Lautropia best distinguished between Barrett's and controls. And then we added Streptococcus and Enterobacteriaceae. There's also an unspecified genus, Enterobacteroideales. We were actually ultimately able to come up with a 3-taxon signature with an area under the curve of 0.94, which in cross-validation remains pretty robust. And then this is just the area, this is just the actual graphic of the curve. And then using the optimal cutoff for this, sensitivity is almost 97% with 88% specificity with this 3 microbiome signature. And this remains significantly associated with Barrett's even after you adjust for all these other factors, including the differences between the groups. We then looked at just the non-dysplastic Barrett's patients, comparing them to the controls, and really found no difference in terms of the predictability of this signature. And then we went and looked and actually did sort of a qPCR for Lautropia, Streptococcus, and Enterobacteria to try and confirm what we found from the 16S data, and really found very similar findings there as well. And so, this is obviously a very small study. It needs to be validated in larger populations. But it raised the possibility that you could conceivably come up with a multiplex PCR test for perhaps 3 or 4 bacteria that could be a point of care test in the office. You just spit in a container, and that just gets sent off for PCR, and you can get very rapid results. Now, the bacteria in the mouth also can produce what are called volatile organic compounds. And so breath testing has been done for various types of cancers: lung cancer, prostate, brain cancer. And these volatile organic compounds exist in the gaseous phase, and they're produced by fermentation of non-starch polysaccharides by the bacteria. And this can actually be indirectly measured by something called this eNose. And in a study from the Mayo Clinic, they found that this eNose could distinguish between Barrett's and non-Barrett's patients with about 80% sensitivity and specificity. So once Barrett's is diagnosed, though, what do we do? What do we do with these patients? Because we're going to be sort of, if we do implement widespread screening, we're going to be flooding the market with all these new Barrett's patients. And is this a good thing or not? So they're all going to enter surveillance, presumably. Now, when we do surveillance, we're assuming that early detection leads to improved outcomes. This is, I'd say, a highly debatable assumption, and certainly, we do know that for cancer, esophageal cancer diagnosis, symptomatic stages has a dismal prognosis, and that if we can stage shift to earlier stages, then we can potentially reduce mortality. In terms of early dysplasia detection, if we can detect them at least at the stage of high-grade dysplasia, maybe we can eradicate and lower the esophageal cancer risk. So these are the assumptions. Does surveillance actually reduce mortality? And I would say there's conflicting data here, and these are all from large, well-conducted studies. This is a population-based study from Northern Ireland. This is one using the VA database, and both of those suggest that yes, it does reduce cancer mortality. A study from Doug Corley using Kaiser Permanente database suggests no, it doesn't reduce mortality. And I thought a very interesting study from Holland where they said, well, it maybe reduces mortality if surveillance is done appropriately in terms at least of the intervals that are done. They found that when there was inadequate surveillance, there was no improvement in mortality, but when there's, quote, adequate surveillance, based on their definition, they actually did see a reduction in mortality. And a lot of, one of the complications of all cancer screening programs is the issue of both lead time and length time bias. And so, if you diagnose early, does it really make a difference as opposed to if you have diagnosed it later? And then secondly, you're selectively going to be identifying these slower developing tumors. And that's just the nature of all screening programs. So, So one of the thoughts is that perhaps if we can detect dysplasia early, since there are some known shortcomings of surveillance, then maybe we can improve outcomes. We know that dysplasia may not be visible with white light. It can be patchy, missed by random biopsies. There's poor adherence to the Seattle protocol, which is the 4-quadrant biopsies every 2 centimeters. And so maybe a wide field imaging modality can serve as a way to highlight these areas of dysplasia. I would say that I'm upfront, I am a skeptic of imaging for Barrett's and its role. And a very nice study where they, out of Holland, where they pooled data from 5 trials of autofluorescence imaging, which is, we don't have available here, but is used there. And all of these trials had very nicely showed that you can really increase the detection of high-grade or of high-grade dysplasia in these patients. But when you actually look, they then said, well, let's look at the diagnostic value. So what percent of patients were identified only by targeted biopsies that were seen on imaging and no other sampling? And then when you go back and reanalyze the data, they found that in those 5 trials, it was 2%. And this is in a very high prevalence, in populations with very high prevalence of high-grade dysplasia or cancer. You can go back and reanalyze the data from the narrowband imaging studies as well, and you get very similar diagnostic values. If you then translate this to a general surveillance population of non-dysplastic patients with a very low incidence of progression, your diagnostic value is probably going to be less than 0.1% in these patients. So it really kind of raises, I think, the question in terms of what's the value, at least for the general Barrett's population. There's some interest in looking at combining biomarkers with imaging, data from autofluorescence imaging that shows that you can detect dysplasia you can detect more dysplasia in patients who have abnormal AFI areas, but the dysplasia is not in the abnormal AFI areas. It turns out the genetic abnormalities are being picked up by the AFI, and the dysplasia may be elsewhere. And so some really, I would say, sort of cutting-edge work is being done. This is by Eric Seibel at University of Washington and Tom Wang at Michigan to actually try and quantitatively image through fluorescence. And basically what they're able to do is through various techniques that I really can't fully comprehend, they can actually just through imaging and various filter techniques quantify different areas that light up. And then what Tom Wang is doing is actually coming up with topically applied fluorescence peptides that are molecular probes that actually bind to proteins that are expressed on the surface. And then those can actually be imaged and then potentially quantified. And so, this is, I think, some very interesting, very novel work. I think it remains to be seen what the use will be in clinical practice. And I think with dysplasia detection, you have to think: is this a fix for a problem that doesn't exist? Is this really important to detect dysplasia? And is early detection of dysplasia? You have to ask: is this our PSA? And are we identifying a lot of patients who really aren't going to die from esophageal cancer? If we detect early dysplasia and treat them, are we really doing them any benefit? And patients under surveillance, the mortality rate, the cancer mortality rate is extremely low to begin with. So the bar is very high for any new intervention in terms of whether or not it's beneficial for the patients. So, going back to the question of screening, we're going to identify all these new patients with Barrett's, but very few of them will get cancer. So then, is it possible that we can come up with a way to risk stratify them, to figure out who's really more likely to go on to get cancer and who's not, and the ones who aren't, maybe we can just forget about them. And so currently we use this sort of one-size-fits-all approach. There's some clinical factors that have been associated with progression: male sex, smoking, length of Barrett's, baseline confirmed low-grade dysplasia. Other studies have shown that advanced age as well. And so, I know I, in practice, will sometimes tailor my intervals at least a little bit based on the individual patient, frequently based on length of Barrett's as well. And there's been interest in biomarkers. I think P53 is probably the one that's been the best studied and is certainly the most promising. And these are mostly studies using immunohistochemistry. This is just one study here, but that shows that abnormal P53 expression, both in non-dysplastic and in patients with low grade, seems to indicate a population that's at higher risk for progression. There's some issues with immunohistochemistry staining, both in terms of really related to interpretation, because there is some baseline P53, and you're looking for either overexpression or absence of expression. And at least in my experience, having reviewed these with the pathologist, it's not always so clear-cut whether or not the P53 staining is abnormal. There's interest in looking at P53 mutations. P53 is by far the most mutated gene in esophageal cancer, and it seems in a lot of high-grade dysplasia, it's also seen as well. And so there's a lot of interest in looking at P53 for P53 mutations, specifically, especially as sequencing costs are starting to come down, and that could potentially serve as a biomarker. Abnormal ploidy probably is also a good biomarker as well, but at least to date, it hasn't come out in sort of a easily measurable form that could be applied to the clinical setting. So lastly, so what to do with high-risk patients and non-dysplastic patients? Should we be ablating them? And so for high-risk non-dysplastic patients, I'm not going to talk about low-grade, but I think there are a lot of issues. I generally discourage the non-dysplastics from any kind of ablation. The rate of eradication of intestinal metaplasia is not 100%. It's actually about 80%. There's a not insignificant recurrence rate of intestinal metaplasia. Probably anywhere between 20 to 30% of patients will have it recur. It can recur with dysplasia or even cancer down the road, so they still need to get ongoing surveillance. And there's actually some data to suggest that the people who don't respond are the ones who have more genetic abnormalities to begin with. And so perhaps those are the ones who are at highest risk for getting cancer. So in terms of, are you actually reducing the risk of non-dysplastic patients if you ablate them, risk of cancer? I think that's very debatable. I'm going to skip this just for the sake of time, but there have basically been several trials looking at, trying to look at different chemoprevention agents in Barrett's. There's one here in particular called the ASPECT trial. According to their website, the data is coming out this year. This was started, I think, in 2004, a randomized trial of 2,500 patients in Europe. They gave lower high-dose esomeprazole combined with either aspirin or no aspirin, and their endpoint is actually a hard endpoint compared to a biomarker endpoint. They're looking at progression to high-grade dysplasia and cancer. Sort of waiting with interest to see what the results of that trial are. We've been interested in looking at gastrin as a potential and blocking the effects of gastrin in Barrett's. It binds to the cholecystokinin 2 receptor, and at least in experimental settings, it seems that it can have pro-inflammatory effects and potentially proneoplastic effects. There's a very nice population-based nested case control study from Kaiser in California, where they found that from elevated baseline gastrin from serum collected in the late 1960s was a strong risk factor for developing colon cancer many years later. And we found in Barrett's patients, just a cross-sectional study, that in patients with the highest levels of gastrin, they had about a 5-fold increased odds of having had dysplasia or cancer. From Tim Long's lab, from their Barrett's and esophageal cancer mouse model, paper published this past year, hypergastronemia promoted the development of neoplasia. Omeprazole increased gastrin and also promoted neoplasia in these mice. And if you block the CCK2 receptor with this drug here, YO476, then that actually slowed the progression. Now, important to keep in mind in mice don't have acid reflux. So this is not the point of this study is not to say that omeprazole increases the risk of esophageal adenocarcinoma, but that perhaps omeprazole-induced hypergastronemia could have some detrimental effects. And so we just recently completed a randomized double-blind placebo-controlled trial of this drug now called natazapide, 476, this gastrin receptor antagonist, in patients with non-dysplastic Barrett's. And we're currently in the process of data analysis, and hopefully later this year we'll have the results of that. And lastly, so we also, going back to the microbiome, so we just did a proof of concept trial because the idea, if the oral microbiome influences the esophagus, and the esophageal microbiome could play a role in disease pathogenesis related to Barrett's and esophageal cancer, then if you modify the oral microbiome, maybe you can influence disease risk. And so we just completed a proof of concept randomized trial where we gave patients for 2 weeks, they took Paradex or chlorhexidine, very commonly used antibacterial mouth rinse for 2 weeks. And then this was prior to undergoing endoscopy. We collected oral samples before and after, and then so we could compare within individual changes, and then looking at between group changes in the esophageal microbiome. And we're just in the process of analyzing this data as well. And so this is just my last slide here, but just to talk about sort of the sum everything up, what's the future? And so I think potentially we could be heading towards non-endoscopic screening. And then once you have a new Barrett's diagnosis, I think obviously if there's prevalent dysplasia or cancer, you'll go for endoscopic therapy. But if not, then hopefully we'll be able to risk stratify patients. For high-risk patients, perhaps either chemoprevention, endoscopic therapy, enhanced surveillance. I think it's a little unclear, but there's a lot of work being done right now to try and figure this out. And these are just my acknowledgments. A lot of this work, especially the microbiome work, is highly multidisciplinary, and I wouldn't be able to do it without the collaboration of numerous investigators. And so with that, thank you.
So now, what about giving PPIs to patients with Barrett's esophagus, which is what is often done? First of all, patients are increasingly skeptical about taking PPIs. And all these anecdotes about problems with PPIs. And now you're telling us that by raising the gastrin, you may be actually promoting carcinogenesis.
Yes, yeah.
So do you prescribe PPIs routinely for all your patients with Barrett's?
Yeah, all of them. Yeah, I give all of them PPIs, and the reason is that
blockers won't do it.
well, possibly. So the reason for the PPIs is, I think the preponderance of evidence points to a cancer prevention effect of omeprazole or PPIs, and that's at least from if you look at epidemiologic data. Again, these are all observational studies. These are not randomized controlled trials, but observational studies seem to show a pretty strong reduced risk of esophageal cancer in Barrett's patients who take PPIs. And we also know that PPIs reduce cellular proliferation. And Barrett's tissue on the whole has pretty high proliferation rates and clearly reduces it. In terms of other effects that it may be causing, that's not really that well explored. But I think that certainly some patients, there's a lot of variability in the hypergastrinemia that's induced. And it's really only, I would say, in a minority of patients who have really high gastrins from the PPIs. And I probably would think that as a whole, you're getting more cancer preventive effects than cancer promoting effects with PPI use. Now, you may be able to ultimately identify patients where maybe that balance is shifted. But the H2RAs is not enough data in terms of either cancer prevention effects or what's going on at the biologic level to say one way or another if they may be useful.
I thought the cytosponge is pretty interesting. Fit testing we send all the time. You have a stool sample, the alpha leave never comes back. You drop a capsule, like that right there could be potentially a high yield screening test. My question is, I know that fit testing is like a parallel, like it's not a perfect sensitivity, right? So they do it every year. How often would you have to repeat the cytosponge as a initial screening?
Yeah, no, that's a good question. I think I think the value. So the issue with screening for Barrett's. So this is a disease that does not have high prevalence. It's very low, actually, right? So even with an enriched population, you might be able to get up to 5%. Even a very good test is still going to give you, a post-test probability, maybe 30 or 40%. So in other words, I think the value for a lot of these tests will be if you can come up with a very sensitive test, then you can at least rule out Barrett's, and then probably with a single test. And then if it's equivocal, you can either repeat the test or you just send them for endoscopy at that point. But I think that's where it's going to be. I think the question will be, can repeated cytosponge testing, can it be used for monitoring disease for patients with confirmed Barrett's? And I think there's real promise there as well. There's not really as much published data there. But, we're not going to have, I think it's unlikely we're going to have a tissue transglutaminase antibody for Barrett's, which is really highly sensitive and specific, right? It's a disease with similar prevalence, but that test is sensitivity and specificity are so high that it's diagnostic. Your post-test probability goes way up. So. You mean like the pill cam? Like, yeah, the cytosponge, is a capsule, and then.
She's talking about like the small bowel capsule, the ESO capsule.
Yeah, that. Yeah, I haven't seen much new on it. It turns out that it's not great at visualizing the esophagus. They've tried to come up with some modifications to it so they can keep it in the esophagus for longer, and that may work. But again, I think then there is some level of interpretation then that goes into that. I think moving towards the direction of something that can just be ordered in the primary care office and taken out there, no subjectivity, there would be a preferable test. But yeah. Great. Thank you very much.